Good afternoon. Welcome to our session on dialysis care collaboration at home. My name is Akshay Collins, and I'm an associate professor of medicine at George Washington University. I'm a busy clinical nephrologist taking care of patients at 4 hospitals and 15 dialysis clinics throughout Washington, D.C. and Prince George's County. I'm also the medical director of a center that specializes in home dialysis. During this session, we'll explore the benefits of home dialysis from the provider as well as the patient side. And we'll also have a conversation with various experts on your dialysis healthcare team and explain how they all work together to support your kidney health. So first, we will introduce our first speaker, who is Andy Gross, who joined the Marine Corps in 2005. And he was honorably discharged and medically retired, graduated with a degree in business management, and then enrolled in the Pittsburgh Institute of Aeronautics some years later. Right before COVID, he had to complete a test for his aviation license and found out that he was feeling weak in his legs and that his kidneys were failing. He then moved back home and was listed for a dual liver and kidney transplant at Geisinger Medical Hospital. And that ended up beginning dialysis in 2021, doing in-center hemodialysis, and later switched to home hemodialysis. Our second speaker is Beth Witten. She's a clinical social worker who's worked with people with kidney disease for over 40 years. She's actually served on local and national NKF committees and wrote the original NKF Kidney Disease Outcomes Quality Initiative guidelines on functioning and well-being. She's a writer, researcher, and outreach expert and has performed in many of these forums for topics that involve looking at dialysis treatments that fit with your values, how to best pay for your treatments, how to find and keep a job, and live your best life with kidney disease. Our third speaker is Lindsay Sipple. She's worked as a registered nurse since 2008 and entered the field of dialysis in 2016. And her passion for educating and supporting the dialysis community have led her to start a YouTube channel to provide valuable information and resources for patients, caregivers, as well as healthcare professionals involved with dialysis. So let's start with Andy. If you could give us a bit of background about your journey that led you to choosing home dialysis, what was going on in your life, how you ended up making the decision that you made.
Well, first of all, I was really sick. I weighed about 127 pounds when I moved home, and I was in center for a few months and just seeing what was going on. It's like I wanted to live and asked if there was different options other than in center, and found out about home hemo and said, sign me up immediately. Unfortunately, the wait list was really long where I was at in central PA, but I finally got in there for training. It's September of 2021 with my mother, who is a retired teacher. She's no nurse, but we did the 6 weeks of training and also had an abdominal hernia surgery in between. But I got that done, and then I was at home. And it is so much more gentler on your body. And that's one of the main reasons why I switched to home hemo, because it's so much more gentler on your body. My recovery time in center was 8 to 12 hours. I'd be shivering cold, just felt sick. But when I'm done doing dialysis at home, I can go mow the grass by hand. And I couldn't do that before. Just your overall health is much better, I believe, on home dialysis, just because of the gentleness of the machine and the more frequent use of it too. That pretty much sums up that story. But I'm glad I made the decision to go home. I couldn't have made a better decision. My team is the best team in the planet, and I went from the sick trail kid to run with my dog.
And that's really awesome. I want to focus a little bit on getting that conversation started, because something was going on in your life that told you that you needed to look for other options. So you, as an individual who's experiencing in-center hemodialysis, What specifically beyond that issue of, having a long recovery time after dialysis, were you experiencing that told you it's time to start the conversation? And in what way did you start that conversation with your nephrologist about switching treatment modalities?
Just to be honest with you, it was the other people that were in there as well. They, they, I don't know how to explain it. It seemed like they didn't want to go on, but I did. And I'm trying to find the words for this. My home hemo nurse, I did not know her at the time, and she heard that I was asking for other options because she knew I did not like seeing the other people in there, and I had life left. I had a lot of life left to live, and it just seemed like those folks gave up, and that's not something I wanted to be around. I wanted to be around good, positive things. And as soon as my home hemo nurse and I chatted for a little bit, we decided that home hemo was probably the best decision for me at the time.
Awesome.
Even though it takes a lot of work to do home dialysis. You have to order your own supplies. You have to do everything with your machine. If something breaks down, you got to call and take care of business. But if you got the time, go home.
Yeah, I'll tell you, when I start this conversation with my patients, I first do ask that open-ended question, like, what is going on with your dialysis? What is your level of satisfaction with the care that you're receiving? What symptoms are you having related to dialysis? And I think, Andy, you really hit it on the head. The question I often ask is, how long does it take for you to feel like you're back to your regular self? And I've heard, answers ranging from an hour all the way up until the next day, where if the person's doing in-center dialysis, they're basically knocked out for the rest of that day, and they shouldn't schedule any other appointments or commitments until the following day. The other thing that I'll often ask my patients is, what activities do they feel like they're limited from participating in while they're on in-center hemodialysis? And for many people, that is their employment, that may be church activities because they have Bible study on Wednesday and they can't make it to Bible study afterwards. Even chores around the house. You mentioned mowing the lawn but by hand. And then I'll often ask, if you've been educated on home dialysis, because particularly for home hemodialysis, that only represents about 1% of all people who are, receiving dialysis treatment in this country. So many people simply have not been educated on it. Their clinic might not even offer it. So many times patients have to change clinics just in order to have access to home hemodialysis specifically. So I think, bringing the education to the patients is, it is certainly our responsibility as nephrologists, as well as the other members on our care team, just to make sure that our patients are as well educated as possible about all of the treatment options that are at their disposal. I'll often bring to their attention. You're in a position where sometimes the router is misbehaving with the internet, for completing your treatments. And you have to be responsible for all of that. And then I ask my patients, what is their why? What drives them to want to keep going? For many people, it's to be able to remain gainfully employed. Other people simply want to live for themselves. Others will say, I want to live for my children or my grandchildren. And we will then offer a home dialysis as a method for them to be able to achieve those goals. I'll often describe the skill set of learning how to do home dialysis as trying to learn how to operate a motor vehicle for the very first time. So if you have an 8th grade education and your hands work and your eyes work, chances are you can do home dialysis. So I think the barrier to entry isn't as high as people might have thought that it was. And there have been surveys done on this before where patients have been surveyed asking what are their hangups about switching to home hemodialysis. Physicians and other healthcare professionals on the nephrology team have been asked that. And there is not a lot of overlap in the answers that people give. very often the kidney team will underestimate their patient's ability to do home dialysis. But that's much lower on the list of concerns that most of our home patients will state. They'll often state, well, do I have enough space in my house for the supplies? Uh, or will I actually be able to do this treatment, all on my own? I think there's a certain fear of making that transition. So, Andy, have you had any of those issues when you were looking to make the transition to home dialysis?
Yeah, I wanted to add something onto what I said earlier, Dr.
Yeah.
Collins. One of the main reasons why I wanted to go home is because of the freedom of home hemo. In center, you were on a strict schedule,
Yeah.
Monday, Wednesday, Friday, or Thursday, or Tuesday, Thursday, or Saturday for 4.5 hours. You were locked into that time. Home hemo, you get to choose when you want to do treatment, and you can travel with your machine. And my dialysis center will even send me my supplies to wherever I'm going, or even out of country. So,
Absolutely.
yes,
Where's the farthest you've traveled so far?
South Carolina, about 600 miles.
Very good. Excellent. And I certainly have a patient in my practice who's gone to Playa del Carmen in Mexico with her
Okay.
home hemodialysis machine. And I think for most people on in-center hemodialysis, they couldn't even wrap their minds around going to a foreign country with their dialysis schedule. And I think what's so tricky about those sorts of things, you go on a beach vacation, you want to be sightseeing in the middle of the day. But if you travel to a place where you're only doing in-center hemodialysis, when are those places open? They're open between 6:30 a.m. and 4 p.m. when you'd rather be seeing the sights. So these people, like you, Andy, you're able to go to South Carolina, you can see the sights, and then you can actually do your treatment when you get back to your room after hours when no one else is engaged in any activities outside of the house. So I think people's quality of life tend to rise. Now, of course, that doesn't come without a certain amount of commitment and buy-in from everyone else on the healthcare team. So everyone else needs to know what our patients who are traveling are doing. So now we're going to turn to Beth, and I want to really get a good idea from you of what role you play as the dialysis social worker and how you can help patients with kidney failure, cope with their disease, set goals for their treatment, and choose a treatment that fits their lifestyle.
Well, first of all, I want to let people know that a little bit about social workers, because a lot of times people have misconceptions about what a social worker is or what a social worker does. So, social workers that work in dialysis have a master's degree in social work. In fact, social workers may be the second most highly educated professional on the dialysis team, except for the physician. Many people don't know what a social worker does. A lot of people know that we do things related to financial needs, but the requirements for social workers, the Medicare requires social workers to conduct a psychosocial assessment. So we get in there and we ask all kinds of nosy questions. So if patients are on this call and have been asked about, their family, their support system, their work history, their any legal issues that they have, their understanding of kidney disease, how they've coped with illness this time as well as in the past, and what do they know about their treatment, and what do they know about other treatment options. Those are the kinds of things that social workers are going to be asking. And they usually do that within the first month, and then they do it again 3 months later. And then if the patient remains stable all year, you may not get those same questions for a year. There's also a survey that social workers do to look at how people are getting along physically, mentally, whether they feel like kidney disease is affecting their life, and in what ways, what symptoms and problems they have physically, and then also how burdensome the treatment is. And from that survey, that kind of helps the dialysis staff know where there are areas that work needs to be done, what interventions may be could help that patient do better, live longer, live better, be able to do the things that they want to do. The other thing that social workers spend a lot of time doing is identifying what resources a patient may need to help them keep their job or find a new job, help them to understand what laws protect them, the Americans with Disabilities Act, Family and Medical Leave Act, what accommodations they can ask for from an employer so that, you know, they can maintain their standard of living. If a patient has to go on Social Security disability or even worse, SSI, their income drops dramatically, and that can not only affect the things that they want to do or need to do, the bills that they have to pay, but it can be pretty darn depressing and anxiety provoking. So we also help people understand what they can do to pay for their treatment. You know, how different programs can help: Medicare, Medicaid, job-based insurance, Medigap plans, Part D plans. Right now, by the way, you can be looking at your Part D plan options. I encourage everybody to do that. We also are called on to help people figure out how they're going to get back and forth to the dialysis clinic. And maybe that might be for the 3 times a week dialysis, or maybe it's only for clinic appointments. But some people that live in rural areas have limited transportation resources. We also work with the nurse and the dietitian around, you know, where can people get the drugs or the nutrition supplements that they need to help them stay healthy. Then it's always the safe and affordable housing. So maybe working with various programs around that. We also, what I really enjoyed doing was educating patients about kidney disease and options. I'm a real big home dialysis enthusiast. I worked at a clinic where we had over 40% of our patients at home, and some of them were doing PD, some of them were doing home hemo. Age didn't make any difference. We had elderly patients that lived in you know, rent subsidized housing. And back in my early days, machines were a lot different from what they are today. So, and I worked with the team on helping them to make sure that the patients understood things, that the education was provided in language that patients could understand. Because sometimes we talk in acronyms and in medical language, and patients will nod, and you think they understand, and they don't. And then addressing their needs, and like I said, the interventions and supporting their goals. One thing you talked about, Dr. Collins, was helping patients choose a plan and how you talk to patients. And unfortunately, a lot of doctors don't ask those questions from what I've heard. So the organization that I consult with, Medical Education Institute, has developed a decision aid that can help patients look at how different treatments fit with what's important to them. Like, do they want to travel? Like Andy was talking about traveling. Do they want to keep their job? Do they want to stay out of the hospital? Those are the kinds of things that they can look at, and then look at how the different treatments fit with what they value the most. And so that then could be something they could take to their doctor when they have those discussions about choices of treatment, and say, well, it looks like on this decision aid, I have more stars for this particular treatment. You know, how would that work with my health condition? You know, so can open up a dialogue. And then we serve as patient advocates. I saw myself as advocating for what the patient wanted. You know, sometimes the clinic wasn't thrilled with me in doing that, but I felt like that was my responsibility, to be the patient's voice. If the patient didn't feel like they felt comfortable speaking up, I would speak up for them.
Absolutely. You know, thank you so much for everything that you do. I think, you know, for us as nephrologists, we're so often hyper focused on making sure that we're checking all the check boxes when our patients come in for their visits, making sure that their anemia is being managed, that their fluid is under control, that their blood pressure is where it's supposed to be, that they're taking their phosphorus binders. It's so important that we're thinking about the entire person. What is that person's hopes? What are their fears? What are their dreams? What keeps them motivated in order to, be the best version of themselves? So, Beth, well, what I'd like to hear from you, can you share with us any example where your assessment of a patient and you're diving into their lives and figuring out what really motivates them led to a change in treatment, particularly a person who was on in-center hemodialysis, that you were able to find an opportunity to transition them to home based on your assessment?
One that kind of sticks in my head is I had a patient who was probably in her 30s, and she had little children. She had 3 kids that were in school. She was doing in-center dialysis, and people looked on her. She kind of had, she kind of looked like she maybe wasn't the cleanest person in the world, and she wanted to do peritoneal dialysis. We had talked about that, especially with having little kids at home and having to, be there when they got home from school. And we talked about that, and we decided to that she may not look like she washed her hair all that often, but that doesn't necessarily mean that she couldn't take care of herself at home doing peritoneal dialysis, which is what they did eventually get her on. And she did really well. She was able to take care of her children, and she lived a good life on peritoneal dialysis. And it was something that I felt strongly that I needed to advocate for her to get the treatment that she wanted. And the perceptions that people had about her were not, actually what was going on in her life.
Absolutely. I think, we often make assumptions about our patients and what they're capable of doing. And what you did, you pierced that veil, and you realized that maybe her appearance was the fact that she was in-center dialysis, and that if she could actually go home, maybe her hygiene would improve. Maybe her appearance would improve because she would just overall feel better. So I want to thank both Andy and Beth for the excellent discussion so far. For anyone who's just joining us, we want to thank you, for being part of dialysis at home. You're tuned into our session titled Care Collaboration at Home. So we will have a Q&A at the end of the session. I know a lot of you have already dropped your comments in the chat box. Continue to drop those questions, and we'll address them in about 10 or 15 minutes. So now we're going to turn to Lindsay, who is our home dialysis nurse. So we want to hear directly from you. What is your role as a home dialysis nurse, and how does your role differ compared to an in-center hemodialysis nurse?
Yeah, thank you. Home dialysis and in-center dialysis is very different. So it makes sense that the nurse's role is also going to look very different. And the home dialysis nurse does require additional, specialized training to teach patients how to perform dialysis at home. And there is a big focus on patient education, self-management, catheter care, troubleshooting the machines, and recognizing complications. Where the in-center dialysis nurse, the focus is a little different. Their training is primarily to administer dialysis treatments at a clinic or hospital setting, where they monitor multiple patients at the same time. So there the focus shifts a little bit more to where the nurse does have to focus on the dialysis machine, because they're the ones managing the machine, where at home the patient is learning how to manage the machine. And that kind of leads us to how the responsibilities of each nurse differs, where the home dialysis nurse, we're working very closely with the patients and families to provide education and ongoing support for at-home treatment. And this definitely involves more individualized care and really empowering the patient to manage their own treatment. It's such a powerful experience to witness patients the autonomy and just the power that they feel and how much better that they feel knowing that they can do this. They are able to do this. And it doesn't mean that the home dialysis nurse doesn't do any kind of hands-on care, like we'll help with the initial setup and do periodic check-ins, but the patient does most of the hands-on care with the machine. And then you go to the in-center and the dialysis nurse is providing more direct patient care, setting up the machine, hooking up the machine, monitoring the vitals, their vital signs, their fluid balance, their machine operation, where at home we're more of a support. We work a little bit more remotely, which is a change, but also it's very exciting. You definitely you get a lot of trust and build relationships with that.
Absolutely. You had mentioned, about how you are trying to empower them and help them build their confidence. When you are taking that patient home, and I know many of our home nurses, they actually do the home visit. Right. So you do the visit, you see how the machine is set up in the home to make sure that everything is safe. In what ways do the home visits help you see what's going on with the patients? And in what ways do you think that helps increase our patients' confidence when they're doing home dialysis?
Gosh, it's just so powerful because, we have all these old ideas of what hard stops are for home dialysis.
Mm-hmm.
And I think of people, like we mentioned storage, like they're like, I just do not have enough room for all of these supplies. And just kind of just smashing that old idea, because if the person is willing to do this home dialysis,
Mm-hmm.
we can find a way to make it work, whether it's changing how often they get their deliveries, and just being positive and supportive, and like your space isn't that small, like we can make this work, we can help you, because once they start feeling better and just get that confidence built, it's like seeing a brand new patient. Like even when I work at a hospital, and it's rare, but when the home dialysis patients are hospitalized, they're the ones that are helping me sometimes. They're the ones that are talking to me like I'm too dry, or, I'm full of fluid. It's just to watch them change and take control of their care. It's an amazing thing to witness. So willingness
Awesome.
is the key that opens the door, I feel like.
Yeah, so I want to actually very quickly ask Andy this, since Lindsay brought that up. I typically tell my home hemodialysis patients that they need about half of a coat closet's worth of space in order to store the boxes. Is that accurate, or is that way off? You're still on mute, Andy. Try that one more time. Still muted? I think you probably pressed it and then pressed it one more time. There we go.
Due to me. No, that is not accurate. I have a table in my basement that is stacked 5 feet high with boxes of sacks, packs, cartridges, boxes. My goodness. And I have a pack or two under my bed. And I have 2 boxes of saline bags in my closet. So yes, you need more than a closet.
Yeah. I usually tell them that, and that's if it's stacked all the way up to the ceiling, then probably half a coat closet. But I appreciate you giving that real world example of the various places that you need to put the materials, just so that you can, have enough space for everything.
Yeah,
right, I want to ask. Yeah, go ahead.
Yeah, things have gotten much better. Once, like Lindsay had said, once you get experience with things, you're like a brand new person. We do shipping, or excuse me, they do ordering once a month through Next Day online. And I have too many supplies, I just put 0.
Yep. And then you end up ordering less. It's one of those things, almost trial and error. Like you have to see how many things are coming, and then you'll slow the shipments down as you get used to seeing how much space you need to take up. So, I wanted to focus on this issue of what's happening in the home, right? Because this is affecting storage space and, being at home, whoever is going through the dialysis procedure, that's not the only person who's affected by it. Dialysis and end-stage kidney disease affects everyone in the house. So I wanted to think about, how dialysis can have an emotional toll on the entire family. So Beth, I wanted to ask you, how do you provide emotional support to family members to make sure that they don't burn out? Because many times our home dialysis patients are, having family members assist them with their treatment or the setup or breakdown of the machine. And your side is muted as well, so you can unmute right before you speak.
Sorry about that.
No worries.
So one thing that's really important, and I hope there's some home training nurses on this call as well, is that patients, unless there's some reason why they can't be primarily in charge, like Andy is in charge of his treatment, his mom is there to be an extra pair of hands if he needs it. So part of what a social worker needs to do with the care partner is to encourage them to allow the patient and encourage the patient to do as much of their treatment as they can do. Because what can happen to care partners is that they treat it like an acute illness. And, with acute illnesses, you have people that help you do everything while you're acutely ill. And then you get better and they back off. Well, kidney disease is a chronic illness, and people are going to have days that they feel good and days that they don't feel great. And there are times that the care partner will take over and do too much. And then the patient will kind of like having somebody do those things for them and stop doing things they could do. And then the care partner can burn out. And so I would keep in touch with the care partners and encourage them to let me know what was going on. And sometimes they would tell me things and say, don't tell my husband this, but blah, 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 blah. And then I would talk to the husband and I would say, tell me a little bit more about what's going on with this. And I would
find out what's really going on.
Find out more to be able to help them to make sure that they were, respecting their care partner's needs as well as their own. So,
of course, thank you so much for that. I wanted to bring in one tidbit related to that home issue. We will often offer our patients respite therapy, if the care partner is feeling like they're on the verge of burning out, or they'll feel like they can't take a trip, and we'll tell the care partner, why don't you just bring, the patient, we'll do a treatment in center for a couple of days. The patient's still going to do everything, but that way, if you're worried that they can't be at home alone, and many of our patients can do, alone treatment. We'll touch base with Andy about that in just a moment, but we will offer that to our patients, and then the patient feels refreshed. They feel like they're taking pressure off of their care partner to always be physically present for every single treatment. And then the care partner also feels refreshed. They feel, rejuvenated because they actually were able to have a break, because call it whatever you want, but this is a part-time job, when we're shifting the responsibility. So in order for our patients to be consistent, so Lindsay, I'm going to ask you to unmute and speak up. How can you help our patients maintain a consistent and clear plan of care when they have this ongoing, as Beth mentioned, chronic illness that requires, constant attention?
Oh, yeah. Thank you. Definitely education, lots of education and open communication, regular check-ins. This can be a telephone call, a video visit. It could be time for a home visit, and including the family members or the support system in the care. So everybody's on the same page. And It feels like at first that like, oh my gosh, home dialysis, you're alone. I'm alone. I'm going to be doing this alone. But you're not. Speaking as a home dialysis nurse, there's a lot going on in the background with technology. We can see how your treatments are going. We can see if you've been having a lot of alarms. We can see your blood pressure, and those can kind of key us into to instigate these regular check-ins too. So, and just making sure that they have the resources at home, what to do in case of an emergency, who to call, having 24/7 support, and just being open and making those check-ins regularly, I think will be.
Thank you very much, Lindsay. So now we're going to transition to our Q&A segment of this session. I know many of you have submitted questions in the chat box. We've received a number of them, and we're going to try to answer as many of them as possible. So our first question I'm going to direct to Andy, because we had started this conversation about care partners and burnout, and you had mentioned, working with doing the training with your mom. These days, are you doing the treatments all by yourself? If so, how often, how involved is your mother at this point? And what would the scene look like if she was not around to assist with the treatments?
If she was not around, I would not be doing home hemo.
Okay.
And who was it that said something about respite? That was the best thing ever invented. I don't know if it's an acronym or not, but just in case. I don't want my mom to get burned out. And she says that she's not, but I can tell because she's my mom. And I'll just call up my home nurse and she'll say, hey, come on in. We got a chair time for you tomorrow morning at 8:30.
Yeah, it's so wonderful having that option, just
Yes.
because we don't want to put all the pressure on the care partner. And for everyone in the audience, I want to be very clear. Back in 2017, the FDA actually changed their guidelines and allowed for treatments to be done at home for patients who are willing and able to do treatments without a care partner. So there is no rule that states that you 100% must have a care partner. I would say probably 80% of my patients who do home hemo do have a care partner, but there are those who can do it or who choose to do it without one. So, and that's why, what Beth mentioned as far as doing that social work assessment, really diving in and finding out what each person's motivations are, what their capabilities are, where their mental health is, all of that plays a role in figuring out the best treatment for that person. So I just want to make sure that people can get over that hang up of considering that they might not be able to do home dialysis just because they don't have a care partner who lives with them all the time. But for Andy, I'm so glad that you do have that, because as you said, you might not be doing this if you didn't have a care partner available. And that's a very real thing for many people. So I wanted to turn to Lindsay, is looking at the training for home dialysis. Like, what does that actually involve? What are you counseling your patients on when you're getting them from zero all the way up to you're ready to go home?
Yeah, it's very much first things first, because looking at the whole picture, it's just like, oh my gosh, how am I ever going to learn all of this? And it's really just one day at a time, one practice step at a time, and being very supportive of their improvements. Like, they're not going to know everything right away. It's going to take practice, and it's going to take phone calls. And from my experience with, like, specifically the peritoneal dialysis, home dialysis program, the Monday through Friday, but by Thursday or Friday, they're like, I'm good, Lindsay, I'm ready to go. I can do this. I'll call you at home. Do I really have to come in tomorrow on Friday to do this? They're so motivated and willing. It's wonderful.
Awesome. So for Beth, what I want to know from you is, obviously for most of your patients who are doing home dialysis, most of them transition from in-center. I mean, I certainly have some patients who go from clinic straight to home dialysis, but I would argue that the majority of my patients come from in-center and then we transition them home. In what way does your role change when they transition from in-center hemodialysis to either home hemo or peritoneal dialysis, as far as the assessments that you're doing, the questions that you're asking?
I pretty much ask similar things. I may delve in more to, who do you have for support at home if you're going to do your home dialysis? Do they feel like they need a care partner? There are safety measures that are done for patients to be able to do dialysis solo that maybe they wouldn't necessarily have to have if they're doing like I'm talking home hemo really. If they're doing that with a care partner who's there all the time. I actually had patients that I had one patient that worked for an ambulance company that was owned by his father, and he did his dialysis in the ambulance office. And, he didn't really have somebody right there with him, but they were around. I had other patients that, they would be doing dialysis in their dialysis room, whatever room they had set up in their home to do that. And their care partner wasn't sitting right next to them. They were, somewhere else in the house fixing dinner or doing whatever. So, they don't have to be just staring at you. And then there's also nocturnal dialysis that patients do hemodialysis overnight while they sleep, and they may have a wetness alarm on to be able to let them know if there's leakage around their access or around the needle. And their care partner they may have a care partner in bed with them, but that person's asleep. They're not awake watching the person do dialysis. So, there are a lot of myths that are out there and misconceptions that we need to clear up so that people know that they could do this. They really could do this.
I see Andy nodding his head, and I'm thinking about the patients that I've successfully transitioned to home hemodialysis. And I think one of their biggest fears that comes up are these times when patients who are on insulin hemodialysis crash, where their blood pressure drops, the nurse has to give saline because we're trying to remove 3.5 liters in 3.5 hours, and that's way faster than what the human body would normally do through the kidneys. And what I typically remind my patients is we're not removing the fluid as fast when you're doing it at home. You're not doing as much fluid removal per treatment when you're doing it at home because you're doing it more often. Andy, what's been your experience with that?
Well, at first, when I was at home, I'd like to get my treatments done as fast as possible based on my flow fraction. But with time and practice, you become a master. I have slowed down my speed to 8.5 dialysate rate per hour. And the more time you're on, the more urea or waste your body gets rid of. And the slower you run, the better you feel. How do I explain this? When you got pressures in your blood, one's faster than the other, it's going to create a disturbance. And that's why you kind of feel like junk.
Absolutely.
Higher speed, but slower and smoother is the name of the game. You get rid of more weight, you feel much better after treatment.
The way I explain it to my patients is, the kidneys work 24 hours a day. So if you're only doing dialysis 3 days a week, you're trying to cram 48 hours of kidney work into about 3.5 hours. So if you switch to home hemodialysis, you're spreading the cleaning out over more hours. So it's less of a shock to the body because the waste levels, the fluid levels aren't dropping from such a high level to such a low level in a short period of time, because that's what causes that rebound. That's what causes that 12-hour recovery, is this shock to the system. So if you slow it down, do the treatment over more days per week, then you don't allow the toxins to reach such a dramatic level that bringing them down results in exactly what you mentioned, 8 to 12 hours of more or less being out of commission. Last question I'm going to ask Beth, why do you think some people are not given the option of home dialysis?
Oh my. I think a lot of people are not offered that option because of our perceptions, and because some physicians have biases towards certain treatments. they perceive it's easier to take care of patients when they're in center, and they can go from patient to patient to patient to patient to patient on rounds, as opposed to having a patient at home. And they don't realize that the home training nurse is the one that the main workload falls on. The physician, I mean, you could say this more than me, but it seems to me that the physician, comes in for clinic visits and occasionally gets phone calls from patients, but the nurse is running all the interference. And
Absolutely. Thank you, Lindsay.
I had nurses that left a clinic that I was at and went to another clinic, and the patients would follow the nurse because they were so connected to their nurse.
Awesome. So thank you so much for that perspective. I think we as nephrologists, it is our job to educate our patients about home dialysis, let them know that this is possible, and basically present all of the options to them. Now, in prior years, there was an issue with not having cross-trained nurses, where we had nurses who only knew in-center and didn't know home, nurses who only knew peritoneal and didn't know home hemo. So I think now that we have more cross-trained nurses, I think that's going to play a major role in elevating the status of home hemodialysis, specifically what Andy's going through, so that we can make both home dialysis modalities be viewed as equal, as opposed to one necessarily being better than the other. Each one is different, is better for different people. But in my view, you're best off at home if possible, rather than being in center. So home hemo and peritoneal are both better than home, in my professional opinion. And I think Andy, Beth, and Lindsay would agree with that as well. So I want to thank all three of you for this engaging, informative, and inspiring dialogue. I hope that the audience found the information that we shared today helpful. We really appreciate the questions that you submitted. This is our last session for Dialysis at Home 2024. Up next is our closing remarks from President and CEO Laverne Burton at 2 p.m. Please follow us on social media or visit kidneyfund.org to find out about more resources. Thank you, everyone.
Thank you.